All right, whoops. Where'd it go? What do y'all see? Do y'all see a PowerPoint? Yes, okay. My computer went crazy for a second. Okay, let me minimize this window. Okay, documentation in the medical record. Now, this does say chapter 9. I don't know if it's the same chapter in your edition, but you do have a second book for this class that's all about documentation. That whole book is on writing notes and documentation and SOAP notes. So that whole book will help you with today's lesson and this week's assignment and this week's practice. Okay, so what is documentation? Anything that we do with our patient, anything that is said between the patient and us, anything that is said by family members or caregivers, all of that needs to go in the documentation, in the medical record. Anything that we do as far as our interventions with our exercises or modalities that we do, education that we give, we have to document all that, because the basic rule is if it didn't document, it didn't happen. So if the doctor needs to look at your notes to get a good idea of what's been going on in therapy, what you've been doing with them, they're going to go back and look at your notes. Well, if your notes are not detailed on what you've been doing every session, on the new things that's been happening with the patient, on how they've been progressing, or if any new injuries have occurred, if you didn't write any of that stuff down, then nobody else, no other person of the healthcare team knows what's going on. So we have to, everything that happens and is said has to be wrote down. Insurance companies, big lookers of our documentation. They look through every single letter that we document, because they're, believe it or not, insurance companies and Medicare are looking for ways to deny claims. They're looking for ways to not pay things. They don't want to pay for what we do. So they look for ways to deny our claims. Well, if our documentation isn't sound and not detailed enough, they can say, oh, we're not going to pay you for this session. And then you've just done a whole session with a person for an hour and you're not going to get paid for it or reimbursed. So you've got to be very detailed. So I've already just said this about reimbursement. The document must describe the effectiveness of the PT and show the evidence of the patient's improving. So every note has to show not only what they did, but how they've improved over the last session. Or maybe if they're not improving from session to session, maybe if it's a long drawn out illness or injury, maybe you can say, well, maybe it's not session to session, but maybe from week to week they're showing progress, or from every month to month they're showing progress. Your documentation has to show that. Your documentation has to define the patient problem. So the problem would be their diagnosis, or their medical diagnosis, or their PT diagnosis, like sprained ankle, or lower extremity weakness, or femur fracture, or rotator cuff repair, shoulder weakness. That's the problem. The plan of care is what the PT outlines in their evaluation. And that's everything that can be done. Well, you're going to do parts of the plan of care in your document. So you'll just briefly say in your documentation what part of the plan of care you did today. Maybe you did therapeutic exercise, and you named the exercises you did, and you named how much weight or resistance they use in the reps and sets. That's how you outline the plan of care. Or then you might say hot pack at the end of session for 15 minutes. That's part of the plan of care. Identify barriers to recovery. So if there's anything that's just going to be a barrier or a problem to healing, or a problem in your session, maybe maybe a patient's physical limitations won't let them do certain activities that you need them to do, or they can't get in certain positions that would be beneficial for them to work out and get stronger. So you identify those things. Or if there's any problems between you, like a language barrier, or maybe the caregiver or the spouse is a barrier to recovery because they are always getting in the way and always wanting to get in there and help and always wanting to give their 2 cents and tell you how to do it better. And believe me, that's going to happen a lot more than you think, especially with spouses and caregivers. They're going to tell you how to do your job better. They're going to think that that's a barrier to the recovery. If the caregiver is your barrier, then you got to put that in the documentation. Insurance needs to know that. Doctors needs to know that. And talk about your goals for why you did your PT interventions. If you did upper extremity strengthening today, talk about the goal that you did that for. And the goals are going to be written in the evaluation that the PT does. So you could just reference back to say, today we worked on upper extremity strengthening with 5-pound weights to address long-term goal of getting back to work.
Would there need to be a measurable kind of like 50% patient was able to do 50%, or do you document it as far as patient followed all of his protocols for today?
Good question. So if the patient, if it's just writing the goals, like the PT writes the goals in the initial evaluation, that does need to be specific with numbers, like will be 5 out of 5 in strength in this muscle group, or we'll have 50% less pain in 3 weeks. But for every single day that you see for daily notes, you don't have to be quite so descriptive. You can say patient is displaying ability to lift more weight on way to progressing to goal number 3 of upper extremity strengthening. Does that make sense?
Yes, thank you.
Yeah, the goals in the initial evaluation are going to be very specific, but when y'all are going to address the specific goals in your daily notes, you don't have to be that specific on the goals, because that's always part of the note. It can always be referred back to. Okay. You always want to document your patient response to your treatment. Did they respond well? Were they able to lift with more weight today, or did they have more pain today? Did they have less pain today? Did you have to change your treatment? Maybe decrease weight on an exercise or increase weight on an exercise. Legal reasons. Any medical documentation, no matter who writes it, whether it's PTs, PTAs, doctors, OTs, social workers, anybody that has anything to do with the medical record, they can be a subject of legal discourse in the event of a lawsuit. So the more detailed your notes are, the more protected you could be in the event of a lawsuit. So let's give an example. Let's say that you're working in an outpatient ortho clinic and you're working with a patient that had a shoulder surgery, and they get better, and then they're back to their normal strength and they don't have any pain anymore. And then you and the PT decide it's time for discharge. They met all their goals, so they discharge. Well, a year later, somebody got it. Just let somebody back in the room. A year later, that patient comes back and sues your clinic because they say that even though you helped them in the short term, all of their pain and their problems came back, and they got a second opinion, and they should have been doing different types of rehab. So it doesn't matter that they got a second opinion. Anybody can do that. But if they bring that up to a lawyer, the lawyer has the ability to get all of that patient's medical record, and they're going to look through every PT and PTA note that was done. And if there's anything that looks out of the ordinary, like if anything in the plan of care was not followed, or if you as a PTA did something outside of the plan of care or outside of your scope of practice, or if the PT put something in the plan of care that maybe was a little bit too aggressive for the patient and it ended up hurting them in the long run, then that's something that they can come back and sue you on. So you want to make sure that no matter what you do with your patient every day, you put the most detail possible in everything that they say to you. If they say something's hurting, if they say something's better, if they say something's sore, if they tell you, oh, I slipped and fell and hurt my back, but we're working on my shoulder, document all that. Let your PT know, because they've got to know about changes, and you want to make sure that everything is, you're going to cover everything you can in the legal document. Okay.
I know this is kind of stretching, and I know PTAs work under the umbrella of a PT, but I know that there are also physicians who have specific protocols for, say, post-surgical hip, post-surgical knee, and the PT doesn't always agree with what the surgeon is saying that they want done. I mean, would that come into play if there was like a lawsuit or something?
You know, that's a good question. If you do get, and you're right, some doctors do want, like, some doctors do have their own protocols for how they want their patients to be rehabbed. So if a doctor gives us a protocol, like say Dr. Smith has a rotator cuff protocol that he likes all his patients to follow, then we're obligated to follow Dr. Smith's protocol. Now, if we didn't follow Dr. Smith's protocol, then that is something that possibly we could be liable for, because if we're supposed to be following under the physician's guidance and then we're going away from the physician's guidance, then we're kind of going rogue and we're kind of going off on our own. So that would be, if you were doing that as the PTA, you would be in trouble. But if I was your supervisor, I would also be in trouble too, because you're working under my license. So we would both get in trouble.
But then if we didn't, like, if we followed the physician's protocol and the PT is telling us to do something different, and we know that that doctor wants X, Y, Z, do we say, hey, the doctor said this, I'm not going to go against what his protocols are?
In that case, the doctor's protocols are what trumps the PT's.
Okay.
Yes. And in that case, I wouldn't document in my notes that your PT wants you to do these things, but you're going with the doctor's protocols. I would first, before you do anything, I would speak to your supervising PT, let them know that you've got to stay within the doctor's protocols. And if they still don't agree with you, then you need to go to somebody higher, like a manager or somebody in the organization, to let them know that you're not comfortable with that. And if your supervising PT is that manager, then really you legally need to stay within your scope of practice and stay within the doctor's protocol, because that is by far the highest one we need to go by. And then that's the PT's problem. They need to take it up with a PT. Documentation is used for annual reports, like for visit number reports, financial reports, evidence-based practice reports, and as y'all knew from the APTA topics, evidence-based practice is when we use evidence that's been done in the literature, that's been done by countless experiments and been shown to be proven true time and time again. We use documentation to look back at things that we've done in the past and say, well, back over the last few years of looking at patient notes, every time we did this type of exercise, people get better. So maybe we can use this as our evidence-based practice. Just an example. I'm not going to go by all through these things. You can look at this. These are all the things that these are basically all the rules of a note. And this is basically any medical note, but it's specifically for our notes. I will let you know at the top, you need to have the patient's name and date of birth. You need to have the treatment date, and you need to have the time in and out, the time that they started and the time that they stopped. And then while you're writing, if you make a mistake, well, you have to write in ink. You can't write in pencil. So if you make a mistake, you cross it out with one single line. You don't scratch it out. You don't scribble it out. You don't exit out. You make one line through it. It'll still be readable. And then you initial and date, just your initials and the date in little bitty letters above it. And then after that, you just write what you meant to write. Then you sign and print your name at the bottom. So you sign your signature, and you'll put PTA, or for now, you'll put SPTA for student physical therapy assistant. And then you'll put the date. And then after that, you'll print your name just in case your signature is unreadable. But y'all can go through all of that on your own. And you'll see, and I have a blank SOAP note up with tips in the SOAP note folder, so you can look at that too. Types of medical records. Let's go through those are basically the same. Let's get to the SOAP note format, because this is what you need to do. This is basically the format that all therapy documents through. And even now, most documentation nowadays is electronic medical records, and it's a lot of clicking and drop down boxes, but it's all still arranged in the SOAP note format though. Excuse me, I had to have some coffee. So SOAP is just an acronym. It stands for subjective, objective, assessment, and plan. 4 sections. So you can think of your note is going to be divided into 4 sections. So, well, really 5. First will be the heading with the patient's name and date of birth and stuff. Then you have your subjective section, and you'll just label that your S section on a note. That's any information provided by the patient. So subjective means anything that comes from the patient's mouth, anything that the patient tells you. If they tell you that if you ask them how much they're hurting, and they tell you that their pain today is a 4 out of 10 on the pain scale, well, that goes in the subjective section. If they say my shoulder is a little sore today, but it's getting better, that goes in the subjective section. If they say, I didn't sleep very well last night because my back pain kept me up, that goes in the subjective section. If they say my exercises that you gave me are getting a little easier, that goes in the subjective section. Anything they say, anything the spouse says, if they have a hired caregiver and they say that they're having trouble getting them to comply with their exercises, or that they do, the caregiver is helping them with their exercises in the mornings or in the night, then say that. Anything that's said, we need to document. If your subjective section is a whole page long, we need to know everything that's said, because that'll clear us from things. That'll cover our butts. Okay, then the next section is your O, your objective section. Objective is the results of tests that you take and measurements that you take, and anything that you do with the patient, any intervention. So if you measure their range of motion, if you measure their strength, you put that in the objective section. If you measure their walking speed, or if you look at their walking and you analyze it and you talk about what's wrong with it and what's right with it, you put that in the objective section. Any balance test, any walking test, any sitting balance test, any transfer test, you put it all in the objective section. Anything that you do with the patient, exercises you do with them, whether they're new or old, you put it in the objective section. So think of the objective section as all the skilled things that you are going to do with them. Okay. The next section is your A, your assessment section. This is their overall response to the whole session. So you're going to say something. If the patient responded well to the session, They were able to go through all their exercises without any problems. You could say something like patient was able to tolerate all activities today without any adverse events. You need to say something about their change in status, like patient was able to lift 2 pounds extra with upper extremities, or patient is still patient remains at same status as last visit in regards to functional goals or transfers or strength. And then you need to say something about your opinion about their progress. PTA thinks that PTA feels that that patient needs to continue sessions to address strengthening to get back to work, or to address pain so he can get back to sports. You need to say something in the assessment section that's functional about that patient's goals and what's important to them. That doesn't make a lot of sense now, but when you start practicing in these assignments I have for you and writing things, it'll make more sense, okay? So your and I will tell you, your assessment section is always your trickiest section to learn. Even going through the next few semesters, the assessment section will be a little tricky for you. So don't get too worried right now if it seems like it's too much for you, because it is a little tricky. The plan section, your P, is what you're going to do on your next session. So you might have seen some notes before that just say continue the plan of care. Well, that's the very, very, very basic thing that you can write. That's the bare minimal. But in any of our classes here at PEMA, if you just write in your plan on your notes, and you're going to have to write a lot of notes, continue plan of care and leave it at that, we're going to give it back to you and ask you to rewrite it. We need to know something else you're going to do, something that you're going to do to progress the patient, like add 5 pounds of weight to bench press or chest press or rows, or trial 6-minute walk test next session, or walk on unstable surfaces next session. Something like that. Something new that they've never done before. Or if it's just something like review or add on to a home exercise program, that could be something that you could plan. Okay, so that's your SOAP note. That's going to be your basic daily documentation note. Every daily visit will have a SOAP note attached to it, and you have to do a SOAP note. It'll either be on here at PEMA, we're going to be doing it on paper, because if you can learn to do it on paper, then you'll be able to really do a great documentation note on a computer. Because on computer, there's a little bit of typing, but it's a lot of drop down boxes and clicking and just clicking numbers. But if you can write it out, then you'll be able to do a very good note on an electronic medical record. So these are different. So just a few more minutes on reports. These are just the different types of reports that we have in our realm in PT and PTA. So we have our initial exam and the evaluation report, which the PT does. That's all the PT's initial findings and their goals and their plan of care. The daily and weekly notes are what are the treatment notes. So whoever sees the patient for the treatment, whether it's you or the PT, we're going to write daily or weekly notes. So most places nowadays have went to daily notes. There are still a few like nursing homes and skilled nursing facilities out there where they just write weekly notes, where they just write one note for the whole week of therapy. But you can't really get a lot of detail on that. So almost everywhere is daily now. Weekly notes are probably going to be gone by the time you'll get to the clinic. And I don't really think that those are very good anyway. You really have to have a daily note to capture what's going on. Progress reports is like a note that's written once a month, typically, or every 10 visits by the PT. Now, it's almost like a mini examination or evaluation, but it's basically like a progress report that you send to the doctor. Now, this doesn't have to be a whole nother examination and evaluation by the PT. You can do all the measurements and give to the PT as the PTA, and the PT will take your measurements and then compare them to their initial evaluation and write up the progress report. And their progress report will typically have their initial goals that the PT wrote. They'll say the goals that they've met, how they're progressing toward other goals, and they'll probably have some new goals written, like some updated goals. Also in their progress report, they'll have things like updated strength measurements, updated pain scores, updated walking distances, updated balance scores. I mean, you name it, it'll be there. And also on the flip side, if anything is getting worse, that needs to be in the progress report too, because sometimes a doctor can send us a patient with a diagnosis, and we can start seeing them based on that diagnosis and what we found. And then as we're seeing them, we might find, you know what, this patient is not getting better the way that they should be getting better. Well, a progress report would be a perfect time to show that and to show your doctor, hey, look, you told us that this was the diagnosis and we've been treating per that diagnosis, but something's not going right here. So maybe you need to look at him again. That's a good time for to show that on a progress report. And a discharge report is just what it sounds like when the patient's done with therapy, when they've met their goals, or if they've been in therapy too long and their insurance isn't paying for their goals anymore, isn't paying for their therapy, or the patient doesn't want to participate in therapy anymore, or if you have to discharge them because they're being non-compliant, they're not showing up for half of their appointments, and they're not doing the recommendations you give them to do for home exercise, and they're not wearing their braces like you tell them to do. If they're non-compliant and not doing what we recommend, we can discharge them. I mean, we can legally do that as long as we document in enough notes and progress notes that they've been non-compliant. Don't just discharge them in like on the fly, like just for no reason, just say it one day, say, oh, you've been non-compliant, I'm going to discharge you. You need to give them several chances. But you know, after you give them several chances and they've been non-compliant, you can tell if they're being non-compliant, because if they're not getting any better, if they get a little bit better but they're not getting as better as you think they need to be getting, and pain's not changing, and they're admitting they're not doing everything you tell them to do, then yeah, you can discharge them.
Would you document the words patient non-compliant with?
Yes, that you would. You would document patient, and you would even anytime patient, you know, you would, and if you think your patient's not doing their home exercise program, always ask them, and whatever they say, put that in the subjective report, in your daily note. And then when you write your progress note, you can put on date on, and you can go back to your daily notes on this date, on this date, on this date, patient voiced not doing home exercise program. Or you could say on several daily visits, patient voiced not being compliant with home exercise program. But yes, you would definitely document that, because you need ammo for you to protect yourself. Because if you're going to discharge somebody early, you need to protect yourself as to why you did that and to why you made that decision. Now, remember, the decision ultimately lies with the PT, but you have a lot of say-so in it too.
What if you're giving the patient, or the PT is giving home exercises for you to give to the patient, and you can tell that they are not doing them? Does that count as not being compliant? And they're saying that they are doing them?
If they say that they're doing them, that's a good question. If they say that they're doing them, then we really can't hold anything against them. But if they say that they're doing them and then they're still not getting any better, or they're not getting better the way we think they are, we can, in that case, we can kind of we can kind of make the inference that they probably aren't being compliant, and we can document patient voices compliance with home exercise program. However, patient's progress is not progressing with his report, something like that. Does that make sense?
I guess in a way, that's like in a nice way of putting it, that we think that the patient's lying.
In the nicest possible way saying it. You're never going to say they're lying, but in the nicest possible way saying it, say you don't think that they're doing what they're supposed to be doing. Yes. Basically, that's how you say it. Okay. I'm not going to go through these things. These are on the other PowerPoint y'all can go through, but this is everything that the PT would get on an initial exam. And we went through some of this in other sessions, where it says evaluation data, test and measurements. That's just going to be range of motion measurements, strength measurements, scores for tests, balance scores, walking scores. Where it says patient history, prior level of function means the way they were before they got sick or injured, or before whatever they're seeing us for happened to them. So that could be working full time, taking care of their family, golfing on the weekends, and now they can't do that. Or that could be a little retired 80-year-old man who just needs to be able to walk around his house every day and feed himself and walk to the mailbox every day. If that's his prior level of function, and that's important to him, then we're going to get him back to walking to his mailbox every day and to walk to his kitchen. And if that's as much as we can do for him, well, we've changed his life. So then we've got him back to his prior level of function. Prior level of function is going to be totally different for everybody. Then you're going to have short-term goals and long-term goals. Short-term goals are usually they're goals that can be attained between 1 and 3 weeks, or 1 to 4 weeks. And long-term goals are more like 4 to 6, 4 to 8 weeks. And those goals are usually, we can always update those goals as we're going along. Patient history, medical history, why their chief complaint, why they're there to see you, any of their other medical history. When we say past medical history or comorbidities, you're going to hear the word comorbidities a lot. Comorbidities just means other diagnoses or illnesses that they have besides the one that they're seeing you for. So that they might be seeing you for low back pain, but they have a comorbidity of high blood pressure and diabetes. And their lifestyle, and that just means, are they sedentary? Are they more couch potatoes? Are they active? Are they athletic? Are they on their feet most of their day, walking in their job, or do they sit at their job most of the day at the desk? Are they a college student that's walking campus all the time, or are they a retiree that just sits in front of the TV most of the day and is pretty deconditioned? That's what we mean by lifestyle. How active are they? What is their nutrition like? Do they take in a lot of salt and fat? Are they pretty fit? Those things like that. All those things make sense. Pain, you always need to ask about pain. Not just what are you hurting anywhere, but the location of the pain and what it feels like. So you can ask them, where's the pain? You can give them a little diagram and they can draw on it. You want to ask them where the pain is and how bad it is. So you can give them a numeric rating scale and say and this is the most common rating scale for pain. And it goes from 0 to 10, not 1 to 10, but 0 to 10. 0 is no pain. You feel great. You feel peachy. 10 is the worst pain you've ever imagined, and you have to go to the emergency room. And you would just ask somebody, today on a scale of 0 to 10, are you having any pain? And where is it? And can you describe it for me? And if you say, describe it for me, I want you to say things like, is it shooting? Is it tingling? Is it stabbing? Is it electricity? Is it numbness? Is it just kind of a little bit of, it just feels tingly or numb compared to the other side or different? Those types of things. Because sometimes they'll confuse numbness and tingling with pain. You want to ask them what makes it better and what makes it worse.
About pain, like,
Yes.
so if some people don't understand the pain scale,
Yeah.
and some people obviously misuse the pain scale on purpose. If they say my pain is a 10 out of or 12 out of 10, are we allowed to use like a flax scale or something like that in our objective note?
Whatever they say, you have to write it down. So, and people do misuse the pain scale a lot. They will say that their pain is higher than it really is, but we have to go by that. Now, if they give you, or if they're sitting there just talking to you and they say, oh yeah, my pain's a 9 out of 10, it's bad. If they're sitting there and they say it like that, you know in your head, this person is not in a 9 out of 10 painter. They would be writhing on the floor screaming right now. But you can say it again. Okay, let me just make sure. 0 is no pain. 10 is emergency room, like you've got a broken bone, a laceration. You feel like you're barely hanging on the light. You're in pain. That's what a 10 is. If they still say they're a 12 out of 10 or a 9 out of 10, you got to write it down.
But can you use like a flax scale in your objective?
When you say flat scale, do you mean like a visual scale?
No, that's like the face, legs, arms.
Yes.
Something. You know, I think it's like a 1 to 5 scale. Like
yeah, you can. Yes, you can do that. You can break it down like that.
Okay.
There are more numeric rating scales than that. Now, let me look for, here's the visual analog scale, which is just, it goes from 1 to 5. And this is used for more kids because kids don't understand a numerical scale, but they can look at a face and look like how bad their pain is. And so we use we use these faces with kids a lot. You can use these other line scales. These might be more what you were just talking about, and you can just get them to look at the line, and they can just make a mark on the line of where their pain is. And we have to believe them, whatever they say, even though we can try to educate them on what the pain really, really, really is and what it probably is. Whatever they say, we have to believe them because it's subjective and it's coming from their mouth. And there's no objective test for pain. There's no medical test in the world to really test for pain. So we have to go by what the patient says. Treatment notes. We already have talked about this all day. We talked about this. Y'all can read through this. Progress reports. Let's see what I missed on discharge report or summary. Yet it must be written by the PTs, but you can get us the information. This is where it says current baseline data. That means everything about the person, their mental status. Well, what's going to be important for us, we're going to be putting the current baseline data, for what they were seeing us for. So their range of motion, their active range of motion, their passive range of motion, how much flexible they are when we stretch them, their strength, how well if they're a low level patient, how well they can move themselves around in the bed and get out of the wheelchair. If they're an ambulatory patient, how well they walk, if they've got any what we call gait deviations, which are things wrong with your walking, we'll name those things. Orthotics or braces. DME is durable medical equipment, any medical equipment they have to take home with them, anything like that. Plan of care in a discharge summary will be like their final home exercise program that we want them to do and how often we want them to do it. Any instructions any final training and instructions we give to their caregiver and their spouse. So if we train if they're going home and they're in a wheelchair, we have to train everybody on helping them get in and out of the wheelchair to get into the car, in the bed, into their dinner chair, into their couch. So we have to give them that education and that training. Well, we're not going to wait till day of discharge to do that because they're going to need a lot of practice together. So, but we will discharge, at the discharge summer, we will definitely say that the caregivers were trained on all aspects of patient's care, whatever that may be. Now, if the patient's going home and they're just an ortho patient and they just had a knee replacement or a rotator cuff replacement and they don't have a caregiver, well, it just might say, the plan of care might just say, continue with home exercise program as appropriate, follow up with doctor as needed. And that would be all. But I will let y'all go through this. Where it says current baseline data, you're only going to do the things that are really most important for what we've been working on. There's a lot of stuff written there, you know, like cognition, mentation, vision, hearing, vitals. We wouldn't be talking about vision so much probably with our patient or cognition unless they were a brain injury patient. And then we would be talking about cognition as far as, can they remember the steps of their getting in and out of the wheelchair that we've showed them? Can they remember the steps of getting in and out of the bathroom that we've taught them? Those kinds of things. These are the, we've already went through that. Here's some examples of what might be in the SOAP note. You might write, patient reports increased knee pain since last visit. Or the patient might say, and you can put quotes, I need to get better faster so I can get back to work. Well, that goes in the subjective section. If the patient has no complaints, if they say there's nothing new, nothing since last visit, I'm the same, you can say no new complaints. And where you see that C/O, C/O is the abbreviation for complains of. So if you see no new CO, that means no new complaints. So if nothing happened, you can just put no new complaints. If they say their home exercise programs are getting easier or their pain is less, you put that in the subjective section. Objective, anything that we do or that can be done by another healthcare provider. So any measurements, any interventions, exercises, anything we did, anything we prescribed to the patient. Here's some examples. Patient performed left quad sets, and that means 2 sets of 20 reps in long sitting. Another example might be right knee flexor strength. It's 4 out of 5, and y'all will know what that scale means later. You might write left wrist extension. Range of motion is 0 to 25 degrees. And y'all would learn to measure that. Y'all will learn to measure that later. Or patient ambulated with assistance using rolling walker for 200 feet on level surfaces. So see, you can't just write patient walked. Patient worked on walking today. Patient walked with a rolling walker. You have to say their device, how far they went, if they needed any assistance. And in this case, this means moderate assistance, and that just means they needed 50% assistance to walk. So they needed help weight shifting or holding themselves up or moving their legs. But then you got to give a distance. And then on level surfaces, that just means they can walk 200 feet with a little bit of assistance on level surfaces with a walker. But if you put them out on a sidewalk, they wouldn't be able to do it because sidewalks are not level. There's an ultrasound example. There's another exercise example. Assessment. Patient's overall response to progress and treatment. Response toward progress toward goals. An explanation as to why the interventions are necessary. You always need to say something, like I said earlier, along the lines of why the patient needs to continue in therapy to get back to something they need to do. So patient needs to continue therapy to get back to work. Patient needs to continue to therapy to get back to pain-free. If it's a kid, and we're seeing a kid, patient needs to be able to have pain-free, no pain, so they can get back to play at recess with no pain. Or they can play on the gym. They can play on the monkey bars with their friends without falling. They have adequate strength to do that, things like that. There's some examples. Plan for next treatment. Also, if you plan to discuss something with the supervising PT, maybe the patient's changes, or you want to change something on you want the PT to change something on the plan of care, then you need to put that in your plan. They say something like, we'll discuss this with PT, or we'll discuss this option with supervising PT before next visit. Here's an example. Just a little bit more about documentation. So we're done with talking about what's in a SOAP note. Just talking about legal documentation. It is patients do have to release. They have to sign a waiver to release that medical information. The medical information, the medical records are the property of the facility, but the patient can see them whenever they are, anytime they want to. And the medical records have to be kept in a safe and secure place for 7 years, and then destroyed, or kept electronically. But the patient always has the right to see their medical records. These are some of the things that I already talked about. When you sign your note, you need to put your name, and then you would put your designation, which for y'all is SPTA, Student Physical Therapy Assistant. And then if you have other degrees or things you want to put after your name, if you've already got other college degrees, you can sign that. If you're an athletic trainer or a certified personal trainer, you can put that after your name or something like that. But this is Dr. D's designation here. So Dr. D has her name, and then her designation as a PT. And then the next one for hers means her highest level of education was her doctorate of physical therapy. She also has a master's. She also has a bachelor's. And then she had her master's and her bachelor's before she got her doctorate, but the doctorate is the higher degree, so it comes first. And then WCS is one of her physical therapy specialties. It stands for wound care specialist. So she's a wound care specialist. She has a special certification. So when I sign my name, I write Joseph Allen, PT/MPT, because I write PT, which is my credential, and then my highest degree is Master's of Physical Therapy. You don't even have to write that. If you want to, you can just write Joseph Allen PT, Dana Chara PT. That's what most people write, unless they have a lot of degrees that they want to write. Like if I had my PhD, I would probably want to write PhD after my name every time, because I want to show off that. But as long as you show your basic credentials, then you're covered. And then print your name at the bottom. Defensible documentation just means anything that is evidence-based care that we have documented that can be used, that we can use as ammo in a court of law. So any of our documentation that is evidence-based, and that we base on standardized tests and standardized measurements in our scope of practice, and things that we know that have been shown to be reliable and to work in our therapy, then we're going to be okay. If we start doing things that are old school methods that have been proven not to work anymore, or we're making up our own exercises or modalities, and somebody doesn't get better and they come back and they sue you, well, if the insurance companies and the lawyers see you're not really using evidence-based practice, well, you've got nothing to stand on. They're going to sue you, and they're going to have a case against you. Computerized documentation, very streamlined. There, if you've ever, we're going to get y'all used to writing the SOAP note, and then then when you go on your clinicals, you would probably most of you will get used to computerized documentation, and it will be so easy. It's a lot of clicking, a lot of check boxes, a little bit of free typing here and there, but it really minimizes paperwork. It keeps track of patients' visits a lot easier. It helps with billing, and it actually helps with reimbursement with insurance companies too. Insurance companies would rather have computerized documentation where everything is much more streamlined from them than handwritten notes. And it improves communication just between the different disciplines of the healthcare team because it's easier to read. And that would be it. So that was it was about an hour on just SOAP notes. But now, any questions? Any question on any of it? Go back through the whole thing.
This doesn't have to do anything with the slides. It's just, where was the documentation PowerPoint? I was trying to look for it, but I couldn't find it.
Oh, it should be. Let me go to my Blackboard. Should be under.
It's on week 5.
Should be under week 5.
Oh, week 5. Okay.
Yeah, week 5.
Okay. And I see that Wednesday we have a SOAP notes assignment due.
It's not this Wednesday. This is we're on this Wednesday. There's not a SOAP note assignment due. We're just going to have live class on Wednesday, and we're just going to practice writing notes together. So there are some worksheets that I want y'all to get started on. Now, you're probably not going to be able to do all of them just after today, but on Wednesday when we have class, well, y'all will be in lab, so I'll have to record it. But I'll give you some verbal examples of like sentences or paragraphs, and then you'll have to and then I want you to try to figure out which section it goes in: subjective, objective, assessment, or plan. Okay.
Okay, thank you. But it says like there's a submission link there. I don't know.
It's for next week.
Okay, thank you.
The link is for next week's assignment. There's plenty of worksheets there. The assignment I'm going to give y'all, your note to write the assignment on is actually there. I think it's called blank SOAP note, but I've got to write your patient's story for y'all to write your note on. So you're not going to submit anything just yet. Everything that's there under that SOAP note assignment folder, that's all practice. Okay, I've got to write your patient's story first. So I will write that this week. I just want to give y'all time to practice first before I throw y'all into the wolves den. But did this make sense today? Subjective, objective, assessment, and plan. Like I said, I know plan, right? I mean, assessment is a little bit tricky, and it will, and if some of you are going to get some assessment and objective things mixed up, that's okay. That's normal at this point. That is common. When that happens, we will correct you, and I'll correct you and tell you why it goes in one section and not the other. And hopefully next week, before next Monday when we're live again. We have Martin Luther King Jr. Day is next Monday. Well, we'll do something live where we go through this before I have the or I'll do something so that we can have like a study session, maybe on a Friday morning or something live, like on a Zoom, where we can go over SOAP notes and stuff, maybe this Friday. So I'm gonna look at my schedule and and I'll set that up and I'll send out an announcement, okay? It won't be during a class day. It'll probably have to be on a Friday morning or something, but we'll have it'll probably be this Friday.
I have a question, but it's not about the class today. So like in our grades in Blackboard, with that IFC test, was that I thought that was a practice test. Is that part of our grade?
It was just it's just as a quiz, but it's not very, it's weighted very low.
Okay, and then some of, like, whenever we did our APTA presentations, and then we turned in our final, like, we already turned one in, and then we turned in our final, it's showing that it needs to be graded, but it's also showing that it has been graded, and I'm thinking it's because there's 2 of them in there.
Oh,
So it's
yeah,
like not showing.
I graded them all. So is that for all of y'all, or is that just Jackie? Is that anybody else too? Have you looked? Sarah is like that. Okay, I'll look. I've graded them all, but I'll go back and look.
Yeah, it's showing that it's graded, but that it still needs grading. But I'm thinking that's because you graded the ones that we sent in, and then the ones that we sent in after that somehow were factored into that, and I it's weird.
Mine is graded, but I only submitted one.
Yeah. Does it show like? Okay.
It shows that it's graded, but it shows the little yellow exclamation at the end too, like it hasn't been completely graded.
So you can't see your grade.
Yeah, it says 100 out of 100.
Oh, okay.
And
okay.
It says graded, but then on the other side, it has the yellow dot that says it's not graded yet.
Okay, I'll look at that. If this happens in the future, if there's a number there, if it shows that it's graded, then you're good. If it's got a little color or a box, it means something that I need to do or something on my end. But as long as there's a number there, everything's good.
Okay.
But if there's an exclamation mark there, then that means that I haven't graded it yet.
I have a question.
Okay.